everybody. My name is Ed Hurwitz. I am the Learning Health System Clinical Champion for Michigan Medicine and one of the co-directors of the Learning Health System Collaboratory. And I'm really excited to welcome everybody today to today's session of the LHS Collaboratory Seminar Series. Today's session is being recorded, and the slides and recording will be available on the LHS Collaboratory website archive. The URL is up there, but you can just Google LHS Collaboratory website, LHS Collaboratory, and it'll come right up. Next slide, Nora. So this is the 2024-2025 LHS Collaboratory series, seminar series, which has the theme of implementation. We want to talk this year about how you get LHS projects moving along. And today's talk is, can we mute, please? Everybody mute, please. Today's talk is building a learning health system in the artificial intelligence era. Next slide, please. And our learning objectives today are to identify the attributes of a learning health system, apply this understanding to incorporating healthcare data and research, improving care, and developing infrastructure to support LHS, and also to understand the practical barriers involved in developing an LHS in a large medical center. Next. So thanks for joining us today. Again, we're being recorded. We kindly request that you keep your mics muted during the presentation. We'll have time for audience Q&A. So please enter your questions throughout the presentation into the chat. Next. So it's a great pleasure that I introduce Dr. Chris Longhurst, who is our speaker today. Dr. Longhurst is the Chief Clinical and Innovation Officer at UC San Diego Health, overseeing various departments, including quality and patient care, care management, information services, and the Jacobs Center for Health Innovation. He's committed to helping transform the way healthcare is delivered. He strategically expanded the function and impact of the Office of Chief Medical Officer to create a high-functioning integrated team of experts focused on UC San Diego Health's journey to become a highly reliable learning health system, which is, of course, something we would love to see in every health system, which is why we asked Chris to come and speak to us today. His role integrates advanced technologies and data-driven models into clinical care, collaborating closely with leaders across UC San Diego to enhance patient outcomes. As the Executive Director of the Joan and Irwin Jacobs Center for Health Innovation, Dr. Longhurst leads initiatives to develop AI algorithms and other innovative health technologies to improve patient care, access, and health equity. He has spearheaded initiatives to integrate digital innovations such as telemedicine, remote monitoring, and predictive analytics into healthcare delivery. He's had many leadership positions even before his roles, and he was Chief Medical Information Officer at Stanford Children's Health before he came to UC San Diego. He's an established author and a fellow of the American College of Medical Informatics. Chris, we're excited to hear your presentation today. Please go right ahead.
Well, thank you very much, Ed. As I was just telling Ed before I joined, sometimes I feel like I'm at UC Michigan with all the folks that have come out west. So Dr. Carruthers and Dr. Karandeep Singh and Michelle Daniel all send their regards. I'm pulling up my slides, and I want to give a shout out to some familiar faces on the line, Leanne and Josh Rubin and others. It's good to see you here. So as Ed mentioned, I'm going to talk about building a highly reliable learning health system in the AI era. And hopefully this will resonate and generate some Q&A and conversation afterwards. So I have no conflicts to disclose. Unfortunately, I'm always looking for some, so please DM me if you have a few. And I'm going to start with a story. This is a story about a patient that I cared for about a decade ago. It wasn't actually this patient. This is a Google image, but you can tell from the picture that this is a teenager with lupus erythematosus. And lupus, of course, is an autoimmune disease that Mott Children's Hospital and Packard Children's, where I was working, and lots of places see in children. But this particular child who was followed by our service was flown in by life flight in extremis. She had multiple signs of end organ failure, pancreatitis. She was losing protein in her urine with nephrotic syndrome. And while I was standing at the bedside admitting her, one of my colleagues from training, Jennifer Frankovich, asked a smart question. She said, you know, with all the protein loss, should we anticoagulate this patient? So, of course, we did what good evidence-based clinicians would do, and we went into the literature and we looked up teenagers and lupus and clotting risk and how many papers were there about clotting risk in teenagers? None. So then we did what good evidence-based clinicians would do, and we asked experts. And the first expert we asked said, absolutely, I would anticoagulate her. Do you remember that patient 6 months ago clotted? And the next one we asked said, absolutely not. I did that once and had horrible, outcomes due to the sequelae from the anticoagulation. And that's when we did something that hadn't been described before, which was that we went to a database and we pulled out similar patients from that database on the date that we admitted this girl. And we found that in our experience at Stanford, over the previous 5 years, 100 patients that were similar in terms of having lupus. And then we divided them into heavy proteinuria versus not, and looked at prevalence of thrombosis. And you can see here what we found was that patients like her were at 8 to 15-fold increased risk of clotting. And based on that, we made the decision to anticoagulate her. So was that the right decision? Well, she didn't have a clot. She didn't develop any sequelae from the anticoagulation. But ultimately, it was an N of 1, and so it didn't answer the question. Now, if this were my daughter or sister admitted to the hospital, I certainly would want clinicians to have access to be able to make the best, most data-driven decisions in the absence of peer-reviewed evidence. But the reality is we still need prospective trials to understand the best approach, right? And so this story got some attention, and in fact, it was cited in the Institute of Medicine report in 2013 about building a learning healthcare system. And this idea of gleaning real-time insights from clinical data or using real-world evidence to make treatment decisions became a quite popular topic. In fact, I partnered with some folks at Stanford, Nigam Shah, who is in biomedical informatics, and Dr. Bob Harrington, who at the time was the chair of medicine. Now he's the dean at Cornell. And Bob Nigam and I described what we thought it would look like to use real-world evidence at the bedside, the point of care. And the irony is that Bob is well known as a clinical trialist in cardiology, and in fact has made his career running 6 or 8 very large clinical trials. But Bob himself will tell you, Chris, I've published 250 papers. 7 of those were about what we randomized to study. The other 243 papers were basically using the observational data we collected from the clinical trial to make new inferences. And so our description of this green button would be that, if there was a guideline available, of course you should use that. If you see a 65-year-old white male with isolated hypertension, well, we know that the studies generated those guidelines are highly applicable, right? VA patients just like that one. But if you see a 45-year-old half Vietnamese female with comorbid asthma, what's the right first-line antihypertensive? Wouldn't it be great if you could use this green button to pull a large cohort of similar patients and use that practice-based evidence along with professional judgment to make a treatment decision? But really importantly, we also described in this the idea that we need to understand these prioritized list of clinical situations when clinicians don't have the evidence that they want to make treatment decisions, and then use that list to randomize at the point of care so that we continuously learn, right? And that point of care randomization is also a really important implication of this green button. So in fact, we just ran our first study at UC San Diego recently, neutralizing antibody study, where we completely integrated it with electronic health records. So using Epic, you could schedule yourself for a research appointment. You could consent for that research appointment. We return results in MyChart, not lab results, but research results. And we wrote about this study recently because we accrued 2,000 participants in this trial in a matter of weeks for a very low cost, right? So EHR-integrated clinical research is clearly the future, but it's not cheap. And we've got to figure out those processes to integrate traditionally disparate clinical research teams with our electronic health record and operations teams. Now, this idea of using aggregate data at bedside has continued to gain momentum, and my colleague Nigam and Bob actually continued some of this work after I left Stanford. They published about this in New England Journal Catalyst and founded a company. I don't have any interest or equity in the company. But what I would say is that at UC San Diego, we recently signed the Epic Cosmos Addendum. And I'm quite excited about this because there's an explicit attempt to try to bring insights to the point of care. In fact, Judy Faulkner acknowledges that the original Lupus paper was part of the motivation for this, um, so that we can build that kind of green button to bring insights to the point of care. And of course, this is complicated and involves a lot of work to quantify patient similarity and control for things like variation using high dimensional propensity scoring. And this is not a solved problem by any means, but places like Michigan and San Diego could play a real role in helping to bring this to the future. I want to shift gears for a second and remind you of another National Academy of Medicine report, which of course came out 25 years ago this month, To Err is Human, which suggested that we kill 50 to 100,000 Americans on an annual basis, or a 747 worth of Americans dying on a daily basis due to medical errors, right? And the follow-up report, Crossing the Quality Chasm, which came out just a couple of years later, suggested that clinical technology was part of that solution. And yet, unfortunately, we know that we have not made nearly as much progress as we've hoped. In fact, I visited Michigan in 2012 when you guys transitioned from the homegrown system to Epic. And part of that transition was to bring computerized physician order entry in a way that would help reduce medication errors and keep patients safe. And yet, we know from Dr. David Bates and others that we've not made nearly enough progress. In fact, it was a lot of David's data that was extrapolated to the original Err is Human report from the Harvard Medical Practice Study in the 90s. He published a follow-up study last year on the safety of inpatient care that found at least 1 in 4 hospitalizations in Boston area were associated with adverse events, and 1 in 4 of those were preventable. So patient safety experts will acknowledge we've made a little bit of progress. Perhaps healthcare acquired infections would be one area we could point to, but not nearly enough, right? In fact, here at UC San Diego, we're one of the top 10% in Vizient for academic medical centers for our patient safety outcomes. And yet we still have over 400 PSIs on an annual basis, which means on average, we have more than 1 PSI per day. And we're a top performing hospital. So we've got to double down. And fortunately, I would argue that we have a new tool that's going to help us get there. So I partnered with Dr. David Klassen and Eric Thomas, some giants in the field of patient safety. And this was actually in the summer of 2022 that we put this together. So before the advent of generative AI, we still found a dozen different ways that it was clear AI could help us to impact this national epidemic of patient safety. So I want to give you a couple of case studies today to spur some conversation. And the first is around chest x-rays, right? Everything from isolated lung nodules to systematic diagnosis. But one example I'll share with you is related to the pandemic. So the pandemic at San Diego actually started about a month prior to the White House declaring it, because in early February of 2020, we were one of 2 sites that received a plane full of expatriates from Wuhan, China. The Miramar Marine Corps Air Services Base, which was where Top Gun was filmed, received 3 planes of expatriates, and the first planes contained patients that tested positive. We hospitalized one of the first 3 patients in the United States. And so we spun up all of our processes and command center 6 weeks before the declaration of the pandemic. And by the time that the pandemic was declared on Friday, March 13th, I was sitting in a room with one of our radiologists who'd had a paper accepted about a machine learning algorithm for COVID pneumonia based off of a data set from Wuhan. And so we agreed we would put that into production based off of the peer-reviewed paper being accepted. And by Friday, March 28th, that was live. And in fact, I remember rounding on Monday, April 1st in the emergency department, asking one of the ED attendings, have you seen this color on the chest x-ray? And she said, oh yeah, over the weekend we had a patient come in for possible heart failure exacerbation, didn't have any respiratory symptoms. We got a chest x-ray to look at the heart. But the chest x-ray had some color. And I said, well, what'd you do? She said, well, we talked to the radiologist, and the radiologist didn't see any pneumonia, but based off the color, we decided to order a COVID test. Now, remember, this was at a time that the COVID tests were extraordinarily difficult to get, right? There were about 10 a day allowed in San Diego County. I said, well, what did the COVID test show? And of course, at that time, we didn't even call it COVID. I think it was SARS-CoV. And she said, well, I don't know. It takes a day or two to come back. So we stood there together looking it up, and sure enough, that test was positive. And you can imagine I followed that patient really closely. She was admitted proactively for developing respiratory symptoms. She did not need critical care. She did well on the floor and went home healthy. And to me, that was a real example of the AI helping make a diagnosis earlier than we would have otherwise. But of course, that was anecdata. And so I wanted to understand if it actually made a quantitative difference. And so I partnered with some colleagues in the emergency department where it seemed like this was helping the most, because it wasn't affecting treatment decisions in the ICU or inpatient floors. In the ED, though, it was clearly impacting clinical decisions. And so we looked at this over the course of the summer of 2020, and we found that 1 in 5 patients who got a chest x-ray, their doctor said this changed a clinical decision, which, as you can imagine, is pretty huge. For those of you who do clinical decision support and BPAs and EPIC and things like that, a 20% predictive value or impact rate is just extraordinary. So this paper really illustrated 2 things for me, though. One was that by the end of 2020, we turned this off because it was no longer helping impact treatment decisions. And in fact, you can see this in the data. While it wasn't statistically significant, there was an extinguishing effect over the course of the summer. Why? Because COVID tests were becoming more ubiquitous, right? By the fall, everybody stepped foot in the waiting room was getting screened. The Biden administration actually put out this blueprint for AI that said exactly that AI should be monitored for adverse outcomes on an ongoing basis rather than a single offsite evaluation. And we know this from CDS, right? This is just the next generation of CDS. You got to keep monitoring to see how it's performing and change it as needed. But the second thing this illustrated to me came about when I found this paper cited a few years later in a review article on all AI papers published for a 2-year period during COVID. It turns out there were 9,000 articles published. And of these 9,000 articles, only 4 were found to actually study clinical outcomes. 2 of those from the US and 2 of them from international sites, I think Saudi Arabia and Israel. And to my surprise, when I looked up those 2 from the US, this was one of the 2. And let me tell you, this was not God's gift to articles, right? This was a survey-based outcome study, right? But what this illustrates is something another review article has shown, that most AI articles about model prototyping and model development, and there's a paucity of clinical outcome evaluation. And this is a real problem because it's what we call the AI paradox. Our friend Karandeep Singh, who's been tremendous recruitment, talks about the fact that most researched models are never implemented, and most implemented models are never researched. And so I would encourage all of you to really focus not on model prototyping or model development, which frankly is the easy part, but on the clinical outcome evaluation, because that's what we're here to do, is to impact real patients in the real world. So let me give you an example of that. And the example comes from sepsis, which is another very well-studied area in AI. In fact, there's been over 3,000 articles on sepsis and AI. And of those 3,000 articles, less than 1%, about 27, have had clinical outcomes. And of those 27, only 2 have actually shown an outcome of meaning to patients. And so I'll tell you about one of those. Of course, I don't have to tell all of you that sepsis is a significant problem. In fact, what I can share is that in San Diego County, where we have about 3.3 million residents, these numbers hold true. So we're about 1% of the US population. We see about 17,000 patients on an annual basis with sepsis. And of those 17,000 patients, about 3,500 will die annually. And so Dr. Shamim Namadi on the lower right there is somebody that I recruited from Emory. And Shamim came out, and I partnered him up with Gabe Wardy in the upper right, who was a medical director of our sepsis care. And together, Shamim and Gabe have done great things to implement his deep learning sepsis model into practice. And in fact, 6 months after Shamim arrived, I said, "How's it going?" And he says, "Chris, I've learned more in the last 6 months than the previous 6 years." I said, "What do you mean?" He says, "Well, sitting on the sepsis committee, I'm starting to understand the workflow, and we can't just fire an alert to the nurse to order labs when they're missing because it's not in her scope of practice. And so we have to get the clinicians involved, but we can't alert the doctors because they might not be at the system, when we fire an alert." I said, "Great, so what are you doing?" "Well, we're looking at process redesign, and we're engaging with our lean improvement team, and we're going to see if we can involve our code team because they have scope of practice to be able to order labs under protocols." And I said, "Well, this is fantastic, Shamim." And he came back to me about 6 months later. He said, "Chris, my algorithm was amazing, but it didn't work." I said, "What do you mean?" He says, "Well, we realized that we're firing it, about 6 hours prior to typical diagnosis of sepsis, but it looks like it's probably inadvertently encoding data that already betrays clinical suspicion. So if we're firing the alert based off a lactate order, the doctor's already thought about sepsis." I said, "Yeah, absolutely." I said, "What are you doing?" He said, "We're going to optimize the algorithm to fire about 12 hours earlier." I said, "I'll bet you're going to lose predictive value." He says, "Yep, but guess what? Look at the impact. That lower predictive value algorithm that was really studied in a real world environment could actually impact mortality in our emergency departments by 17%. That translates to 50 lives saved on an annual basis at UC San Diego." And let me tell you another story. We at the time had two emergency departments, one in La Jolla, one in Hillcrest. La Jolla sees a population that's older, mostly cancer patients. And turns out our clinicians are pretty good at diagnosing sepsis in cancer patients. And there was a 10 to 12% mortality impact in La Jolla. But in Hillcrest, where the population of patients tends to be younger, immunocompromised for different reasons like HIV, there was a 24% impact of this algorithm. In fact, what this AI helped us to do was to close gaps in health equity, right? To improve health disparities because it was trained on our own data. And this gets to another really important point. People talk about bias in algorithms. And I say, sometimes we build our algorithms in order to have bias. It's not bias in algorithms I'm worried about, it's outcomes, it's health equity that I'm worried about, right? And the only way to understand that is to understand it in the real world. Some national, network of assurance labs using a standardized data set isn't going to tell us squat. In fact, the editor of Nature Digital Medicine, Dr. Joe Kvetter, wrote an accompanying editorial that I think was just outstanding. You can see it's called "Integrating AI into Healthcare, More Than Just the Algorithm." And in this, he argues that funding agencies, journals, and researchers need to focus on these outcome studies as opposed to the algorithm studies, the meaningful outcomes that matter to the patients and families that we serve. In fact, there's a table in this article in which Dr. Kvetter and his colleagues outline all the different steps we took beyond just the algorithm, from the post deployment monitoring to the infrastructure that we used to set it up to the processes that we described in the paper. And I think in the editorial, they suggest at least 50% of the outcomes are not due to the algorithm. I'll tell you, we think it's probably more like 80-20. Some of my colleagues here at UC San Diego recently argued that a regulatory strategy for AI should be outcome-centric by requiring companies to demonstrate AI tools produce clinically important differences before being brought to market. And let me tell you, that's not how it's occurring today. In fact, with over 1,000 algorithms approved by the FDA, a recent article by the group out of UPenn showed that less than 10 have actually had real outcome studies. Why is that? Because most 510(k) clearance is being given based off of what they call precedent, right? So similar previous. And yet the Penn group showed that precedence being given to hundreds of algorithms for which there are no AI or ML precedents. So there's something wrong, in my opinion, with how we're regulating this centrally. So this innovation and impact is exactly why we founded the Center for Health Innovation here at UC San Diego Health in 2021. And in 2023, we were the grateful recipients of a large donation from Joan and Erwin Jacobs that really helped to turbocharge our efforts and give us resources to do this outside of the hospital margin. And so that's part of how we recruited Karandeep. And leads us to the next story, which is when Dr. John Ayers called me up in the summer of 2022. Actually, sorry, in late November of 2022. And he said, Chris, have you played with ChatGPT? I said, of course, it's mind-blowing. And he says, Chris, I'm feeding it patient questions and you wouldn't believe the responses. And I said, John, where'd you get patient questions? You don't have access to my chart data. He said, no, I'm getting them from Reddit. And I said, huh. So he sent me a few examples and they were pretty mind-blowing. And so I was one of the 7 reviewers grading these questions. And you probably all saw the clickbait headlines that said that the chatbot was smarter and higher quality and more empathetic than doctors. But that wasn't my takeaway. My takeaway was that I would put my doctor up against a chatbot any day of the week if you gave him 10 or 15 minutes to write a 4-paragraph response. But in fact, that's the problem, right? It's time. Our doctors are crunched for time. And that's what's led to this avalanche of concern over pajama time and too many MyChart messages and after hours work and all of this. And so putting these two ideas together, I called up Judy Faulkner and Sumit Rana at our EHR vendor partner in January of 2023. And I said, hey guys, I've got some outcomes here. We submitted it for publication. And I think it might be a great opportunity to pilot something inside the EHR. And they agreed, and that's how UC San Diego became the first in the country to roll out the AI inbox tool inside of Epic. And Epic asked me, we need somebody else to pilot it. And I said, well, my former institution, Stanford, is great partners. And so we worked on this together. And we designed it together. And we designed it so there's only 2 buttons there. Start with draft and start blank reply. And why is that? It's because we wanted to adhere to our principle of accountability, right? Keeping a human in the loop. And that's a pretty easy one. There's no button that says just send now, right? Everything has to be edited or reviewed before sending. But the next one is more interesting because we have a principle of transparency. And of course, many times you think about that transparency principle as it relates to transparency of algorithms used to generate, or data sets used to generate algorithms, or how those algorithms are applied. But in this case, our AI governance committee said, well, what about transparency with patients if we're using AI? And our clinicians, I'll tell you, said, yeah, we use dot phrases today. We don't have a disclaimer that says, your doctor used .normal labs to respond to you. But this was different, argued our patient and family representative and our clinical ethicist. AI is new and different and scary. And so we decided to move forward, and our Patient Family Advisory Council recommended the verbiage that you see below, which describes exactly what it's doing without using the word AI. It says, part of this message was generated automatically, reviewed and edited by your doctor. How was this received? Well, I'll tell you, locally it was received very well. In fact, after a Wall Street Journal article, one of our primary care physicians, Dr. Millen, actually got a note from one of our patients that said, I'm so glad to see that you have an AI co-pilot because I know how busy you are. And I wanted to be the first patient to send you a bot-generated message so you could send me a bot-generated reply. In fact, this got some attention just recently in the New York Times a couple of weeks ago. Teddy Rosenboth wrote this article, and you can see her agenda a little bit because it says that message from your doctor, it may have been drafted by AI, though many have no clue the replies are software generated. So it starts with a quote from yours truly, talking about why we chose to be transparent with patients to maximize trust. And then it quotes several other health systems who decided not to. And I'll just say that I feel like we chose the right path and would encourage others to do the same. And I think this is an area that we need to come up with some standardization. I'm not sure that the actual workflow that we chose is perfect. I think there's probably other places in the workflow we can disclose. And as AI becomes more and more ubiquitous, it's going to be really important that we're transparent with patients about how we do that. In fact, our story resonated with one of our assembly members locally in California, Lisa Calderon. California had over 50 AI bills in the last session. 6 of those passed and were signed by the governor into law. 2 of them were healthcare related. This is one of the 2, and it was based on our work at UC San Diego. That bill from Lisa Calderon was really simple. It was the shortest bill, and it just requires that any healthcare delivery organization, doctor's office, or health system, using AI to communicate with patients is required to disclose that, whether it's telephonic or in written form. And I think that's a good idea. We also studied the outcomes of this AI inbox tool, and we published those a year after our pilot started, so moving very quickly. And guess what? We actually published them as a randomized study, not as a clinical research trial, but as a randomized QI trial. So credit to Dr. Ming-Tai Seal, who helped to lead that. And you can see Marlene was the penultimate author, and Topher Sharp from Stanford was actually a co-author on ours, and Ming was a co-author on the Stanford study. And you can see some of the quotes from our doctors using this in the randomized trial. And I'll tell you, when we randomized it, it was actually into a group of early adopters and late adopters because all the doctors wanted it. But one of the things that we found that was counterintuitive was that it didn't save time. I was wrong. And we wouldn't have known that if we didn't study it closely, right? But it didn't save time because it turned out before the AI tool, it took about 30 seconds for a doctor to read a short patient question and use a macro or type something in response. After the AI tool, it takes about 30 seconds to read that short patient question, and then the 2 to 3 paragraph AI response, and then make an edit and send it. And so in both the Stanford study and the UC San Diego study, there were no time savings. But in the UC San Diego study, we did find that the responses were about 2.7 times longer when the doctors used the AI tool, suggesting that perhaps they might be perceived as higher quality by patients. And in the Stanford study, where they actually measured burnout using the validated Wechsler tool, they found a decrease in clinician burnout. And so I can tell you, we've continued to roll this out, broadly. And just a couple of weeks ago, C.T. Lin and the group at University of Colorado published a great research letter in JAMA, identifying that in their institution, where they rolled this out to doctors, nurses, and medical assistants, the net promoter score for doctors and nurses was actually negative, right? NPS is minus 100 to positive 100. But nurses loved it. It was like plus 57. And Bob Wachter and Lisa Rottenstein wrote a great accompanying editorial where they opined that it might be that GPT does really well in highly protocolized kind of situations, helping the nurses' workflow the most. But in the more nuanced situations that get escalated to physicians for responses, it's less helpful because it's less able to answer those type of questions. So we're still learning, and this ongoing evaluation and feedback loop is an important part of it. But I really wanted to draw your attention to the fact that we studied this as a QI effort. And the way that we did this was really motivated by this paper from NYU, credit to Dr. Horowitz and colleagues, where they point out that randomization of QI initiatives is the best way to learn. And so we learned from NYU and founded something back in 2020 to help drive QI-based studies. And this is my favorite acronym, ACQUIRE, Aligning and Coordinating QI Research and Evaluation. Dr. El Khairy there chairs this committee. And it really solves 2 problems. The first was as CMO, I was always getting these phone calls from the IRB director. Chris, you know about this quality improvement effort? This doctor says that they should be IRB exempt. And I'd say, well, Tony, we want all of our doctors doing QI, but I don't know about all of it. And so by having this process and encouraging people to submit, we now have a database of over 500 QI studies. And when our residents and fellows and medical students want to do QI, we point them that database. Instead of firing up their own QI effort, we say, why don't you align with this work that's already being done? The second incentive for people to submit, though, is in addition to an IRB excusal letter, we'll also give maintenance of certification credit. And so that's really what's led to the database now of 500 active projects. And of course, there's projects that don't meet the definitions of QI, and they'll go to the IRB for clinical oversight or for research oversight. But if you're interested in AI, you can search this database and you'll find that there's over 24 active QI efforts using AI today. And if you're interested in becoming a cardiologist and you're a internal medicine resident, you can go search for cardiology and you'll find a dozen different cardiology QI projects. So this has been really transformative for our culture as a learning health system. In fact, we wrote about it in a recent paper. But I'll tell you, one of the things that Rob has done that I think helps to encourage that culture change is that on a weekly basis, he actually sends out this complicated PubMed search of all of our medical directors. And it highlights scholarship that our medical directors are producing, including QI-related scholarship. And we celebrate that as an institution. And so Rob wrote this paper along with our Vice Chancellor, Dr. Brenner, about developing a highly reliable learning health system. And it really encompasses this idea that all health systems should be highly reliable, right? Bringing best practices to the sharp edge of care in a reliable way. But a learning health system is something that we're uniquely positioned to do as an academic medical center, to use the data that are the byproduct of care to continuously inform and improve the quality of subsequent care. And that's what this acquire process really supports. In this paper about combining these two concepts of a high reliability and learning health system describes the acquire process in a great deal of detail. And in fact, I love this study from the Hastings report that came out at the same time as the Institute of Medicine report in 2013 about an ethics framework for a learning healthcare system. And it really suggests that just as health professionals and organizations have an obligation to learn, patients have an obligation to contribute to or participate and otherwise facilitate learning. And so lots more that we can talk about in that space, but I want to wrap up and leave time for questions. And I'll wrap up by saying, first of all, that I alluded to earlier, this call for a national network of AI assurance labs. We don't think that's the right place. I partnered with some folks. I met at White House Task Force, Anish Chopra and John Brownstein and others to call for a network of AI implementation science centers studying clinical effectiveness, because that's the only way we're actually going to know what works and what doesn't, because the algorithm predictive value won't tell you squat. And then more recently, I worked with Raj Watwani from MedStar to describe what we believe is a shared responsibility of vendors and health delivery organizations to do this local testing and monitoring. And in fact, you don't often hear a health system leader call for more regulation. This is one place where we think the CMS should include AI governance as a condition of participation, so that auditing agencies like the Joint Commission, when they come to a tracer, could say, hey, we see that this patient came through the ED, got a sepsis alert that looks like it's fired by AI. Can you please tell us your AI governance process and how you manage ongoing monitoring of these AI alerts? And I think that that's the right way, as a civilization, as a society, to monitor this type of work. So I've talked about a lot of different research and ideas. And if you're interested in learning more, scan one of these codes, because I generated an 8-minute podcast from all of these papers. And I'll tell you that this AI podcast is actually more interesting than I am. It's an AI-generated male and female bantering about these papers and about how some of this is like GPS in a cornfield and making jokes and other kind of mind-blowing things. And the X link will actually teach you how to do the same thing with your own research. So I'll wrap up by saying it's our job to figure out how the healthcare system learns from every patient at every visit, every time. And I continue to work on this because of many mentors that made a big difference in my life, including my father, Dr. John Longhurst, and Dr. Atul Butte, who's now at UC San Francisco, and our own CEO, Patty Mason. So thanks for the time. And Ed, I'm looking forward to questions and comments and some discussion.
Well, Chris, thank you. Thank you so much. I'm fascinated. Really don't even know where to start. So I'm going to encourage people to put questions into the chat, or if you want to put an X in the chat, I'll call on you to unmute. But I'd like to start with this, Chris. We think about some of the examples you gave about your lupus patients, sepsis patients, and that kind of thing. You certainly took this methodology into the ambulatory setting where you talked about AI responses, but help me think about a similar situation to making clinical decision making in the, let's say, the non-urgent ambulatory care setting. Where will I use that green button? Is there anything you're working on in that setting where I would want to have a green button that could answer a question for me that's sitting in clinic about say, a non-urgent decision that I could make?
Yeah, so that was certainly part of our idea behind the original green button. And as I said, NIGM went and founded a company that does just that. So you can ask these clinical informatics consult service, for input, and they'll generate a one pager, using real world data to try to help answer a clinical question. The problem, of course, is that the Atropos, based approach is still highly manual. And so, as I mentioned, we did some follow-up work on what it would take to actualize kind of this idea of the green button in an automated way. And it's a lot of work that's not yet done, but that's really the vision of where Epic is going with the Cosmos data at the point of care. And so, now that we're finally signed with Cosmos, we're eager to co-develop in that space and try to figure out how we could use real world data, with the right controls at the point of care. You can imagine that the wrong inferences could be drawn from data if you're not doing sort of the right type of controlling for confounders, et cetera. And so, this is going to have to be done really cautiously and probably with clinical trials as opposed to, as a QI type of effort. But, Zach Kahani recently wrote this great editorial in New England Journal called "The Healthcare We Have." And his point was, as we evaluate these AI-based solutions, we need to compare, the AI-enabled care to the healthcare we have, not to some ideal gold standard. And the truth is today, doctors are making decisions without data every single day, right? In the best studied field of cardiology, where we think the most clinical decisions are actually made using data, it's about 20% of clinical decisions for which there's good level A evidence, right? Which means that 80% of decisions are being informed by data or experience that's clearly not, gold standard. And so there's just so much opportunity. My field as a pediatrician, it's probably like 95% of decisions are made without real evidence. So on the one hand, I think we need to evaluate these tools really carefully. On the other hand, I think we need to do it quickly, not slowly, because there's a better healthcare system that we can enable with this digital infrastructure. And we owe it to our family, to our friends, to our loved ones to get there as quickly as we can.
Yeah, absolutely. Chris, a very interesting question here from Brent Mahan. Can you speak to your thoughts on the role that an AI literacy fluency program can play in supporting a safely, innovative, more effective LHS? I just want to add on to that we have some leadership here at University of Michigan in terms of developing curriculums for medical students around AI and so forth, which I just think is so important. So some of your thoughts about that. Dr. Cornelius James is the leader in that.
Yeah. Well, first of all, I agree with you, Ed. I think it's a really important topic. And, I might even expand it and say what's as or more important than AI literacy. AI literacy is kind of like a bridge for those of us, who were raised in a world without AI. But as we think about like our incoming medical students and trainees who've grown up or will be growing up in a world filled with, generative AI, how do we actually revise all of medical education to incorporate this, right? I mean, people have been predicting for years that simple recall of medical facts is a thing of the past, and we need to teach critical thinking and use of AI and electronic tools. But I think the entire medical education system is going to need a real overhaul because of these tools. I don't have the answers on what that looks like, but I do think that there's going to be a lot of smart people working on this over the next decade or so. For example, I'll say that when I was becoming a pediatrician, there was a prediction that there would be a dearth, a surplus of physicians in pediatrics, within 5 to 10 years, and we all kind of freaked out about having jobs. And then the AAP came out 5 years later, said, we were totally wrong. We're sorry. The prediction was misinformed because we didn't take into account that with 85% women entering the workforce and a preponderance of women choosing part-time careers, that we now actually have a shortage of pediatricians. So it was a forecast that was completely incorrect based off of some false assumptions. Similarly, you can hear predictions today that we're going to have a shortage of primary care physicians. Well, I don't know if that's true. I mean, I think in 5 years, AI-based tools that are helping with diagnostic decision support are going to make not only the average primary care physician into potentially the top performing, but mid-level providers as well. So when you have a healthcare system that has, AI-enabled diagnostic decision support, do you want or need primary care physicians, or should mid-levels be doing all of primary care? I don't know the answer to that, but I think there's some real important questions that should be considered by smart groups of people.
Excellent, excellent thought. A lot of thought about that here in Michigan in terms of bringing more mid-levels into just the kind of things you're talking about. Amy Nutman, since studies have shown that providers will often defer their own better judgment if AI or similar systems suggest a different judgment, even if the providers know the AI suggestion is incorrect. What regulations or culture shifts do you recommend be implemented when utilizing these systems so that they can be helpful, but not overriding to better judgment? I'm a little surprised to hear that perhaps people might say that's wrong, but I'm going to trust it. But maybe that's how it works because we think the computer's smarter than us. Please.
Yeah. Yeah, so that's a great question. And Amy, Dr. Nutman is exactly right that there's a lot of literature showing what's called automation bias. And this literature stretches back decades, but even with basic non-AI, rules-based clinical decision support, there is a trend towards automation bias where, particularly younger clinicians will trust the advice that's coming out of the computer without sort of thinking about it critically. This is a challenge that has faced, fields outside of healthcare as well. And one that has done particularly well is the airline industry. And so one of the ways the airline industry battles automation bias is that even though, the autopilot can essentially take off and land the plane at this point and fly it the whole way, pilots are required to have a certain number of hours, both, taking off and landing themselves and in simulation centers. And so I think that's something that we're going to have to really put a lot more thought into, as we think about continuing medical education is, how do we encourage continued use of critical thinking and get away from, this trend towards automation bias, which is absolutely important. All that being said, I want to say something else, which is that writ large, if AI is actually outperforming humans in decision making, even if automation bias leads to some errors, the errors it's eliminating in human-based judgment may still justify ongoing use. So that's a little bit controversial, but the airline industry has come to terms with that as well.
Wow. For Josh Rubin, we seem to be developing methods building on the learning health system principles to continually optimize getting the right treatment to the right patient at the right time, the right dose, the right form to improve health outcomes. How do you do the same for AI, substituting AI recommendations for the word treatment, get the right AI recommendations to the right patient at the right time, given the lack of studies connecting AI and outcomes you alluded to earlier? That is, moving toward a precision use of AI itself. Interesting. Rather than thinking about AI to help us precision medicine, how do we precision use AI?
Yeah. Well, Josh, that's a very meta question on using AI to kind of get to the process of treatment decisions. And I don't have the answer to that one. I'm not sure actually how to best address it other than, clearly we're seeing AI come into play, not just at the point of care, but in a lot of other situations. So, back office work and even how we build these systems, right? So we're finding AI-based, tools to allow us to do testing, There's an estimate that 50% of all the code written at Google in the last 12 months has been AI generated code. And even using AI to test, one instance or agent of AI to test other ones. And that gets back to the previous question about the automation bias. There's a lot of folks smarter than me who are using AI-based agents to try to double check the AI-based recommendations. So I don't know if it gets at the question that you're asking, Josh.
Chris, I think about this question in terms of the human factor. How do we, there's a lot of human factor in terms of getting AI into the right place in that chain of,
Yeah.
you know,
Well, one of the areas I didn't have time to talk about, of course, that everybody's doing is AI-based scribes, right? And it's kind of a no-brainer because unlike the inbox, most time spent after hours is actually spent on documentation. And Kaiser and others have shown that, clearly these AI scribes can help save time. But what I'm actually most excited about, if you read the Kaiser study in New England Journal Catalyst, is that the AI scribes help to somewhat reduce after hours documentation, but actually has a much bigger impact on reducing time spent in the exam room documenting. And so what it's really doing is it's rehumanizing the experience of seeing patients, right? It's liberating doctors from their keyboards. And to me, that's a great example of AI helping bring humanism back in medicine, getting perhaps peeling back some of the bad things that we've done over the last 20 years by implementing electronic health records.
how interesting. Ambient AI is being tested all over Michigan medicine right
Yep.
now, which I'm looking forward to because when EMR opened in 2012, I would often sit there type and I would say to the patient, I have to put your information into the computer now, so excuse me if I actually look at you once in a while.
Yeah.
So I'm really looking forward to that. It'll be very interesting
Yep.
to see the role that plays.
Yeah, it's going to be the standard of care at every health system in the next 3 years.
Yeah, absolutely. There's a question here from Bucky, who is a PhD student at the Michigan College of Pharmacy, who thanks you very much for this very interesting presentation. Do you have any thoughts on framework, checklists, guides to conduct clinical outcome evaluation of AI in healthcare? Yes, that's the
Yep.
question to help us to move along that path that you were talking about.
Yeah, well, first of all, Bucky, congratulations on being in grad school at Michigan. And yes, there's a saying that the great thing about standards is that there's so many to choose from. And I feel like the great thing about AI frameworks and AI guides is there's so many to choose from, right? Every specialty society has created these. Every National Academy of Medicine has created these. University of California has created these. I'll put a link into our own AI governance principles at UC San Diego, which incorporates the FAVES framework that was put out by the White House and the ONC. But as I pointed out earlier, I think the real rubber hits the road and how you actually apply these frameworks. The checklists, they're all like motherhood and apple pie. Like I honestly think you could choose any of them and you'd be pretty well off with some caveats, right? I pointed out things like talking about reducing bias in AI algorithms, I think is garbage because it's not the bias you're trying to eliminate, it's the health disparities, right? The actual outcomes. And so you can see the principles that we've publicly shared about our AI governance approach. But I actually think that the most important thing, as a PhD student, is looking at these things in practice, right? Sit on an AI governance committee, trace through a proposed, intervention from conception to actual application, and be part of the post-deployment monitoring of that intervention as well. I think that's where the real learning comes in, not the frameworks and guides and checklists.
Chris, we'll take one more from Nicole Templeton. Curious about AI governance. Do you address patient safety work protections or discoverability within that structure?
Yeah, that's a short question with a long answer. So the lawyers will tell you that what's discoverable is anything that gets discovered. That being said, there are things you put in the electronic health record and things that you put elsewhere, right? And so the quality improvement efforts enjoy some protection at a state level, not necessarily at a federal level. or no, sorry, I think I got that backwards. Maybe it's a federal level, not a state. But we have put our AI governance conversations under that umbrella, so that's part of our kind of quality, deliberations. It's not the AI governance output itself is not discoverable, but of course, how those alerts are firing, certainly are.
Chris, I really can't thank you enough. This has been such a wonderful presentation. And I'm just going to put up these slides, if you don't mind, I'll jump in front of you and just do this for the sake of time.
Can I claim CME credit for my own presentation?
I've often wondered about that, so I'm not going to answer that for you. So please, for those of you who are CME, physicians alliance, for example, you can use this QR code for CME, or you can go to the CME website and find this and get CME credit for this presentation. Again, Chris, I can't thank you enough. Again, the slides and the talk will all be available through the LHS Collaboratory website, and I'm sure this is something many of us want to review again to really understand some of the intricacies of how this rolled out and how we can apply it in our own work. The LHS Collaboratory will continue to move on. In December 17th, 2024, we will have our own Michigan Medicine Clinical Implementation Panel, which will feature Dr. Hang on a second.
Dr. Andrew Rosenberg, your CIO and a good friend of mine, and Nicole Templeton, your patient safety officer, and Dr. Watts, your CQO.
Yeah, thank you, Chris. And it should be a really interesting discussion about how we move along developing the infrastructure for learning health system work at the University of Michigan. So again, thanks everybody. And here's the post-event survey. Really appreciate everybody giving feedback on this, and we're interested to know about your thoughts about future collaboratory events.
Thank you so much for joining, and would love to come out to Ann Arbor and visit in person sometime. Feel free to email with follow-up questions. Nice to meet you all. Thanks for the comments.
Okay. Thanks again, Chris. Okay. All right, good day, everybody. Have a good weekend.